my topic actually, I'll be speaking about HSV keratitis, not viral keratitis. That was the original topic. And thank you to AIOS for the opportunity. I think HSV keratitis is something which perplexes many of us all the times, but it is one of the most responsive keratitis and the most gratifying keratitis to treat. So we know that HSV is the only known human reservoir for HSV, and because it is so ubiquitous in all of us, up to 90% of the population may be infected with latent HSV by 60 years of age. Now the clinical manifestations, again, it's important to mention here that diagnosis is mainly clinical. If you can recognize the look, HSV keratitis does not really require any investigations except the occasional PCR for keratouveitis. So it affects all layers of the cornea and going straight from the epithelium to stroma and endothelium, and then also, of course, the uveal tract, the keratouveitis. Now the dendrite is the most characteristic lesion of the HSV keratitis, which has a classic branching linear pattern. If any of us see this, I think being ophthalmologists, it's not something we are going to miss. But often, especially if you're working in a secondary or tertiary hospital, you will not see this because patients, it will have resolved by the time patients come to you, and you may just see some footprint scars. And this is often self-limiting. Now the other thing, the other lesions, so this is another manifestation. I want to make this presentation more photographic. So, you have a patient who's presented like this, and this is a dendrogeographic lesion. There is some map-like pattern along with the geographic lesions. And if there is any confusion, the base stains with fluorescein, and the swollen edges which contain live virus stain with rose bengal, as is seen on the picture at the bottom. And whenever we have to stain, the order should be first rose bengal, quickly followed by fluorescein, because if you stain with fluorescein first, it will diffuse into the center and you will not be able to see the rose bengal staining. A purely geographic ulcer, which is again due to live virus, has to be differentiated from a metaherpetic or a neurotrophic keratitis, which we see in HSV. This is due to live virus. This will often have scalloped margins, which helps it to differentiate from the metaherpetic ulcer or the neurotrophic ulcer, which has smooth borders, sloping edges, and this will show the pattern of reverse staining, where the rose bengal stains the base and the fluorescein is diffusing beyond the edges. Now coming to the one which is more complicated is the stromal keratitis due to HSV. So the majority of morbidity is not due to epithelial disease or due to endothelial disease. It is due to stromal disease. Here, the immune mechanism and live virus both play a role. Sometimes in very fulminant cases, it's difficult to differentiate from bacterial or fungal keratitis, and often the initial treatment may have to be bacterial or fungal because you can't recognize it, and later on as an exclusion you think of viral. And treatment has to be a fine balance between antivirals and steroids. This I'll try to demonstrate through a couple of cases. So now this is what I would call a classic case of HSV stromal keratitis. I have deliberately put up this picture because hypopyon it's not very common, but it is not rare. You will see hypopyon sometimes in cases of HSV stromal keratitis. But what I want everybody to focus on in this area, this stromal inflammation is the hallmark of HSV stromal keratitis. And this is a form of what earlier was known as non-necrotizing stromal keratitis, where there is no epithelial defect. The other form is a stromal keratitis with ulceration. Now this was a patient who was being treated with topical antibacterials and antifungals somewhere, not wrongly I would say, but the clue in this case which would give you an idea that this perhaps may be viral is the area of edema which is extending way beyond the area of the infiltrate. So that gives you an idea that there is a component of significant endothelitis as in association with the stromal keratitis as well. But while I mention this, I would like to say that think viral, but be sure to rule out bacterial and fungal. So in this case, although I would say by clinical suspicion, I was 100% sure this is viral, but I would still not take that risk, especially for the residents and fellows. You should rule out, you should scrape and send for bacterial and fungal. And if it's not just treated for 2 months, 1 more day won't make a difference. Wait for that and then you can start. So just coming to the 2 cases which I mentioned, this patient, if you start with systemic antivirals and steroids, this is the patient after 2 weeks, all inflammation gone. Vision is 636, mainly due to cataract, which improved later after cataract surgery. But again, what I would like to emphasize here is that while the infiltration has gone, if you make a slit, the edema persists. So while the edema persists, you don't need to stop treatment suddenly. You need to give treatment for a little while longer so that both the infiltration as well as the edema goes. And in the second case, again, 3 days after initiation of treatment with antivirals and systemic steroids, so topical steroids were avoided here because of presence of an epithelial defect. The patient cleared up remarkably. Treatment has to be continued for a longer time. And this is what, again, I would like to mention. This is the stromal infiltration. So these are the WBCs in the stroma around the vessels. And so treatment should be continued for a longer time. If we stop it here, the inflammation will continue to smolder and the patient will have chronic vascularization and later on other sequelae. Then coming to, I'm just keeping it to the simpler manifestations. Coming to endothelial keratitis or endotheliitis, it may be disciform, it may be diffuse, or it may be linear. So this was a young girl. Actually, she was a 17-year-old girl who was referred for OPK from outside. You know, somebody thought this is a corneal opacity and was referred. Now, for all the residents sitting here, I would again like to mention, anytime you see a corneal opacity, what you think is a corneal opacity, be sure to please do a slit lamp examination. Look at the thickness. The thickness in the center is more than your thickness in the periphery. The thickness in the center is more than your thickness superiorly. So this is a case of endotheliitis. And this would have KPs below this. If you, after you start steroids and you will see the resolving, I'm sorry, I don't have the follow-up of this. And you can use AIOCMTC2 to see keratic precipitates. Another patient, same, this was a one-eyed lady in fact. Diffuse endotheliitis, sudden onset of edema, no history of trauma. And you see that after you've started the steroids and the antivirals, the KPs appear, and 10 days later, the cornea is much clearer, and of course, later on, treatment was continued. So in stromal disease, the inflammation is much more, whereas in endothelial disease, the edema is much more, although both can coexist. And if not adequately treated, these patients can have long-term sequelae. So you can have the steel wool keratopathy with chronic vascularization and lipid keratopathy, which is then debilitating and would need a keratoplasty, which again is a lifelong challenge. Or if in one eye you have some disease where you are confused what it could be, look at the other eye. If the other eye has these footprint scars, because we know that epithelial disease tends to alternate, if you see the footprint scar in the other eye, you would have a clue that what you are dealing with is HSV keratitis. A quick word about the treatment. Epithelial disease is treated with antivirals, whether systemic or topical. Most often topical suffice. Stromal and endothelial disease has to be treated with a combination of antivirals and steroids. And there needs to be a fine balance depending on the manifestation. I'll just take, if you'll permit me, just 2 more minutes. Not 2 more minutes, maybe 20 seconds more.
Yeah, please go on.
Yeah. So if you have if the stromal inflammation is predominant, one focuses on the steroids more associated with antivirals in a prophylactic dose. Steroids have to be full dose. On the other hand, if it is stromal keratitis with ulceration, which is due to live virus and immune mechanism, you initially give antivirals more, systemic and therapeutic dose, and steroids are held back a little bit. And later on, as the epithelial defect decreases, you give steroids. And finally, endotheliitis is due to both live and immune mechanism, so it has to be a balance between steroids and antivirals in full doses. And the last slide, don't underestimate the risk of excessive steroids, infections, cataract, glaucoma. But don't hesitate to use them when needed. Use the steroids for as little as possible, for as short as possible, but as much as needed and for as long as needed, and that can often have very gratifying results. Thank you.
Thank you, Professor Malhotra. This is a very important topic in our context because this can very easily be secondarily infected, and it's not very uncommon to confuse HSV with fungus and rarely acanthamoeba, because often steroids are the mainstay of treatment in HSV and they might lead to devastating consequences. So I really like that slide of yours where you put up the need for scraping. I think
Yes,
that
absolutely.
cannot be underemphasized
that cannot
anymore.
Be overemphasized, yes,
Sure.
absolutely.
Thank you.